Hi, I'm Brian Teisinger. I'm an assistant research professor here at the Sol Price School of Public Policy, and I direct the microsimulation group that's here at the Schaeffer Center. And so I'll be talking about the kind of work that we've done over the years. And my goals here are to give you an introduction to what we do, to make you better consumers of the kind of microsimulation work that we do so you understand what goes into a microsimulation model and what you might do with it, and then show you a few applications of what we've done with it over the years. Okay, so our health policy microsimulation group, it started in 2004, and we focused on a lot of health policy questions, looking at obesity, smoking, cardiovascular risk factors, delayed aging, cost of dementia, a full set of things. We have two models here at the Schaeffer Center. There's the future elderly model, which is based on the health and retirement study, which is a longitudinal panel study of people who are 51 and older, and so it allows us to answer questions about health at middle age and older. And then we have another survey, another simulation called the Future Americans model, which is based on the panel survey of income dynamics. And for that model, we were able to model people 25 and older, so we can capture the adult life course. Let's see. So we've contributed a lot to different work over the years. We did a National Academy of Sciences report a few years ago. I have some slides on that towards the end. But and we've also contributed to the Social Security Administration in their thinking about retirement policy. So why care about microsimulation? What does it let you do? So there's a lot going on with the US, with the future of the US when you're thinking about risk factors for health, demographic trends, and then the incidence of disease that has resulted from those risk factors. So the microsimulation allows us to look at disease burden, health disparities, healthcare costs, and then also we look at a lot of implications for government programs, looking at Social Security and Medicare and Medicaid. Because there's lots of moving parts going on, so for example, smoking trends are declining, obesity trends are increasing, it isn't obvious how you would disentangle the effects of what's happening. Coupling that with the demographic trends, both the aging of the population and then also the transformation of the population makes things more complicated. And so our modeling allows us to project future risk factors, morbidity, mortality, disability, and these economic outcomes using our data-driven approach. So as I mentioned, we have two models here. So there's the future elderly model, and as I said, it's based on the health and retirement study, modeling people 51 and older. The health and retirement study started in 1992 and continues to this day. It's every 2 years. And so the way you can think about what the future elderly model does is it projects the future of that data set. So you could think when I have a 2030 projection, that's really my best guess of what the health and retirement study might look like in 2030. That data set is designed to be nationally representative, and so that lets us do the US version of the simulation. Over the years, we've also repurposed it so that we do a version for California and a version for Los Angeles County, so we can do more local results for at least the people in this room. And then the future adult model, like I said, based on the panel study of income dynamics, modeling people 25 and older, so we're capturing more of the adult life course. And that one as well we have for the US, California, and Los Angeles County. I don't want to forget that the future elderly model also, the health and retirement study have several sister surveys in Mexico, Europe, England, Ireland, Korea, China, India, et cetera, et cetera, et cetera. And so we have and continue to adapt those surveys to model the future of those countries as well, which allows us to do international comparisons. Okay. Our team here, I don't want to miss them. There's approximately 9 faculty members and fellows who work with the simulation, so it produces a lot of output. The programming team is 4 mathematicians, statisticians, and programmers. So we have 5 doctoral students that are working on the model basically at any given point in time. I'll mention our external collaborators just briefly. So we have collaborators all around the world. We've recently added Trinity College Dublin and the University of Leeds to build out the Irish and English versions of the models. All right, so our current research agenda in our Roybal Center are these 2 goals. So one is to assess policies to mitigate the social consequences of health disparities. And so that really drove a lot of the FAM development that we've done, but we also do a lot within the future elderly model looking at disparities. And then all the international lessons for US aging policy that go to the development of all those other models that I mentioned. Okay, so now I'm going to start getting into sort of the nuts and bolts of what the microsimulation does. And so hopefully you can start to get your head around what all we're modeling. So let's see. So we're modeling health risk factors, chronic diseases, functional limitations, and mortality. That's sort of the health bucket. And then we have a lot of economic variables that we're also going to be modeling. So that's, are people working for pay? Are they getting disability benefits from the government? Have they claimed their public retirement pension from Social Security, a private retirement pension from their employer? And then there's some other federal programs that we're modeling the participation, so like food stamps and things like that. And then the structure of the model is, it's modeled, all the statistical modeling is done on real people. The simulation itself starts with real people as well, so people who are participating in the survey. And then as the simulation runs, we have to bring in some synthetic people that are based on real people. And so the real strength of what we're doing is there's a lot of heterogeneity in the people in the survey. We're modeling all of that and then incorporating it into our projections into the future. So if you've seen kind of the demographic type models that are very cell-based, you know, men 50 to 55 look like this, women 60 to 65 look like that. This is much richer than that because we're really controlling for a lot of characteristics at the individual level. And so we're modeling individuals within the simulation, and then we're going to aggregate up to get our population statistics. All right, so all of the transitions that happen in the simulation, what I mean by that will become clear in a minute, are first-order Markov models. And so if you're not familiar with the first-order Markov model, what that means is that if you think about the way the survey works, let's say someone responded to the survey in 2010 and 2012. We're modeling what happens to them in 2012 based on what we saw in 2010. So the kinds of things we're modeling on the health side are, do people die? Do they have incident cancer, incident diabetes, incident heart disease, et cetera? And all of those things will be predicted by the observations from 2010. So within the data, we're actually pulling together many years of the survey, but it always follows that, that first order assumption. Let's see. So as I mentioned, we have a bunch of chronic health conditions that we're modeling. So our diabetes, heart disease, hypertension, et cetera. We also do a lot on dementia and Alzheimer's disease. That's been a big focus of our work in recent years. We model a whole bunch of ordered outcomes as well. So these are the functional limitations that you're probably used to. Can people dress themselves, bathe themselves, cook for themselves, shop for groceries, those sorts of things. And we're modeling smoking status and mental distress, subjective well-being. And then on the economic side, I think I've mentioned all of these already. I will mention that we're modeling nursing home entry. And so that's a big part of how we're thinking about the aging population. Any questions on that in the room? Yes.
Yes. Well, maybe you'll cover this, but these are all the outcomes. What about the covariates?
Oh, I have some examples of the covariates, but yeah, you could think of if you were doing this from scratch, you would think about anything that is in the survey is a potential covariate. In reality, we haven't built everything out, but it'll be the standard things like age, sex, race, education, and some other things. We'll get there, but thank you. Okay. For example, here are some example translations, and I apologize for the size of this. One time I gave a talk and I had this enormous screen and it looked fantastic, but this will give you a flavor of what's going into the model. So I'm showing two transition models here, and so let me focus on the one on the right. So this is our model for incident diabetes, and so this is going to be estimated on anyone who in the previous wave of the survey said, I don't have diabetes, and in the current wave of the survey, they either answered yes or no. But it's only those people who might be developing diabetes. And so what we're controlling for here are some time invariant characteristics, so their education, their race, and their sex, their relationship status. So in FEM, that is, are they a widow or not? I think we're controlling for whether they're single or not as well. And then we have these time varying things. So here I have risk factors. So the big risk factors for incident diabetes, and the way we're modeling, are age, BMI, and smoking status. Age and BMI are the big drivers here. And then we have the next box below that, these risk factors at age 50. These are characteristics of what the person looked like just before they entered the survey. And so this is trying to put everyone on an equal footing so that, so for example, some of the people enter the survey at age 75, some of the people enter at age 52. But they've asked all of them have you ever been told you have this disease, and how old were you when you got that disease? And so I can control for if they had the disease by age 50. And so we're controlling for their BMI at 50, their cancer, if they'd had cancer by 50, if they had heart disease by 50, et cetera. And then we're going to interact some of the sex and education and sex and race as well. And so this is a probit model. So it's predicting 0-1. Is this person going to develop diabetes in 2 years? And it's all based on the previous wave of the survey. Is that clear to people in the room? OK. On the left, I'm just showing our an additional model. So this is for the grandchild care hours that people are providing. And I included this one just to show you kind of the richness of what we're doing. So it's not just health. It's not just federal program participation. There's also some of these informal kind of care either given or received that we're modeling as well. And so for those, we thought really hard about what you go into a model like this. And so just to give you a sense of what's going on there. OK. I mentioned that it's a very data-driven exercise that we're doing. So I've talked about the health and retirement study a lot so far. So that's going to be our host data and what we're going to use to estimate the transition models. But we're also going to use a lot of additional data products that are out there. So we've done a lot of work with Social Security. And so we have linked Social Security records for respondents in the HRS. And so that lets us do a pretty good job of modeling benefit levels that people receive once they claim Social Security. For Alzheimer's disease, we rely on the ADAMS supplement to the HRS. And so if you're not familiar with that, that's a subset of the HRS, people 70 and older. And they actually did a lot of cognitive assessment of individuals. They had doctors, clinicians, I'll say, assessed if the people actually had dementia or not. And so we're relying on that rather than a self-reportive dementia or a proxy responsive dementia for one of the ways that we model Alzheimer's disease. Let's see. We use some other nationally representative health studies. So we have the National Health Interview Survey and the National Health and Nutrition Examination Survey. And where we're going to rely on those is for understanding trends for our future cohorts. So the future cohorts, that'll come up in just a minute, but these are going to be our synthetic populations that are going to come in as the simulation continues to run. And basically, I need to have some best guess as to what their BMI might look like, what their smoking status might look like, what diseases they might have developed by age 50. So we're going to rely on those data sources for trends in those. For medical costs, which we do a lot of work on, we use 2 data sources. So we use the MEPS, the Medical Expenditure Panel Survey, and we use the MCBS, the Medicare Current Beneficiaries Survey. And so we use the MEPS for the non-Medicare population, and we use the MCBS for the Medicare population. So anyone who's getting disability benefits and qualifies for Medicare that way, or who's aged 65 and older. And then finally, we have some census forecasts and some additional parameters from the literature, and we're using those to get population weights right so that we have the right number of people entering the simulation in any given year. And we're starting with the right number of people. OK. Very data-intensive, data-driven exercise that we're doing. And because of that, the simulation really is a garbage in, garbage out kind of model. Like if we have bad data, we're going to get bad results. And as I've worked with it over the years, what I've learned is that if I'm seeing odd simulation results, 99 times out of 100, it's going to come back to the data that's going in. So we try to spend a lot of time validating that the data are high quality and measuring the things that we want and giving us the right starting point to work with. OK. So now I'm going to talk about 2 types of simulations that we do. So the first is the simpler of the 2. This is a cohort simulation where we're just going to take a group of people and age them through death. And so this is the setup for the cohort simulation. So I'll start with a population of the youngest people available in the HRS in a particular year. So for this slide, I've said it's 51 and 52-year-olds in 2014. And so I'm going to read those people into the simulation, and I'm going to immediately calculate some outcomes for those people. So when I say outcomes, that's going to be things like medical expenditures, Social Security benefits, Medicaid expenditures. We can also calculate disease prevalence and other statistics on the population. OK. Now I'm going to age everyone by 2 years. And yes, I am literally going to add 2 to their age, so that happens. But this is where we're going to apply all these transition models. And so for anyone who in 2014 did not have diabetes, I'm going to predict, do they develop diabetes for 2016? And so the way that's done is we're going to apply that transition model that I showed earlier, come up with a predicted probability of that, do a random draw against a uniform distribution, and then assign yes or no, this person has now developed diabetes. Do you have a question?
Yeah, I was wondering, so it seemed like some of the different outcomes would be kind of jointly determined, but is the thought that they're all estimated with separate probit models, and the extent to which, someone is likely to gain weight and get diabetes and have a functional limitation all at once, that'll be kind of accounted for by the fact that they have the same covariates going in or something like that?
Yeah, so that's a great question. So the question is, are we modeling these things jointly or independently? And we are modeling them independently, but the things that we're controlling for are the things that the joint would probably pick up. That said, historically, people did try to do this jointly, and they ran into problems, technological problems.
Yeah.
And then people also tried including like individual fixed effects. And it turned out that those things just absorbed way too much information of what was going on. And so that's how we ended up with those characteristics at age 50. So it sort of standardizes people in a way that that we're controlling for at least the health stuff in a consistent way.
Or do you also include the characteristics that they were simulated to have in the last period? So now you've taken the draw and now they have diabetes. Will that be a covariate in the next?
Yes, absolutely. So we're going to update all of these things going forward. So yeah, so we'll get there. No. But I'm glad you asked it that way because I'll say that explicitly. Okay, so we've now aged the people 2 years. They've developed diabetes or not. They've passed away or not. They've started claiming Social Security or not. All of these things are now assigned to these individuals. And I'm going to calculate my outcomes for 2016. Okay, and at this point, now I'm going to age them another 2 years. And so in the transition model, now the lagged variable that is going to be used to predict their new status is the one that I had predicted for 2016. So to predict 2018 information, I'm going to use the 2016 information that I updated previously. So all of that does continue to carry forward. What else do I want to say about this? I think that's okay. So at this point, we're just going to turn the crank on the simulation, and we'll calculate our policy outcomes, age people by 2 years, calculate policy outcomes, et cetera, all the way through death. And so what this allows us to do is come up with a lifetime, years worked, years lived, quality-adjusted life years, disability-free life years, the kind of measures that we like to work with. Okay. So this is the simpler of the two types of simulations that we do, but it's really useful. We use it a lot of time in research. The more complicated is this population simulation, and it has a similar structure, but with some additional bells and whistles. So here we're going to start with the population 51 and older. So this is, you could think of it as everyone in the HRS in 2014. And I'm going to do the same thing and calculate these policy outcomes. The policy outcomes here now have a different interpretation. So if I calculate medical spending, this is like total US medical spending for people 51 and older, or Medicare spending is total Medicare expenditures for 2014. I'm going to age the population by 2 years, so applying the same transition models that I've estimated and used before, so it's the same kind of updating of characteristics for all of these individuals. And you see that now everyone who was 51 is now 53, everyone who was 75 is now 77. What I really want, though, is I want to keep everyone 51 and older. And so that's where these replenishing cohorts are going to come in. And so I've added this box here. So for 2016, I'm going to have a replenishing cohort of 51 and 52-year-olds who are going to enter the simulation. And so what those people are is they're synthetic. They're based on actual HRS respondents from a particular year. And then we're adjusting characteristics of them. And that's why they're now synthetic. So the types of things that we're adjusting for these individuals will be the sample weights, so that we have the right number of people coming in. Disease risk factor trends. So I mentioned earlier that people are getting more obese but smoking less. And so we're going to assign characteristics to these people to reflect those trends that we expect to see. And then chronic disease. So if diabetes is rising, our replenishing cohort will have higher diabetes. This is actually the most complicated thing that happens in the simulation. This is all done jointly, and so that, for example, if someone is predicted to have higher obesity, they're also more likely to have diabetes. And so we're preserving the covariance of these conditions as we're increasing or decreasing means. Okay, so now that I've brought those people in, I'm back to a population 51 and older for 2016, and I can calculate all of my policy outcomes again. So I'll have my Medicare expenditure for 2016. Okay, I'm going to now age the population by 2 years again, and so now I had 51 and older, so now it's 53 and older. I'm going to use those transition models I estimated and apply them through these random draws assigned characteristics. I'm going to need a replenishing cohort to come in, and so that's where this group is going to come in. And so this is assigned in a similar way to the 2016 group, but they'll be a little bit more obese and smoke a little bit less and have a little bit more diabetes. So just kind of on the margin, they're changing a little bit. I'll calculate my policy outcomes for 2018, and then I'm going to turn the crank. I'll spend just a minute on this one because now we're in 2020. This is the future, right? So often when I present this, people ask about these 2016 and 2018 cohorts. Why are they synthetic? And the reason they're synthetic is because the 2020 cohort has to be synthetic. And so we're using the same framework to assign the characteristic of all of these cohorts. And so we're actually going to generate replenishing cohorts through 2030 or 2040, depending on how far out we want to forecast. And all of that is going to rely on a lot of assumptions about trends continuing. And yeah, go ahead.
Does the PSID also feed into that? Because those are some of the younger people who will become these.
That's a great question. So she's asking if the FAM version then feeds into the FEM version, the PSID version. And so for now, no. When we initially started building FAM, the idea was that yes, we were going to do it that way. And then we just ended up doing everything soup to nuts in FAM. So we get kind of a full life course projection. That said, we do borrow information between the two simulations. So like the mortality model in FAM is informed by the mortality model that we've estimated for FEM. So it's not entirely independent, but it's not like someone reaches age 50 in FAM and starts in FEM. Yeah. But for particular outcomes that aren't measured in FAM, we can switch over to doing those things using FEM stuff. So if you really cared about dementia for people who are 25 today, when they reach 65 or 70, that would be the approach we'd take. Yeah, great question. Okay, so now we're to 2020, calculate my policy outcomes, and then turn the crank as far out as you're willing to go and believe. I mean, I get pretty skeptical when we go out way too far, but it is what it is. It's the framework, and it feeds out numbers with a consistent set of assumptions, so we always understand what we're producing. Any other questions in the room before I move on? Yeah.
The replenishing cohort, does it get older?
So the question is, do the replenishing cohorts get older? And so yeah, so what happens is the 2016 cohort comes in, they're the 51 and 52-year-olds, and then in 2018, they're now the 53 and 54-year-olds. So their characteristics are getting updated as well. And so we're starting with an actual group of people in the HRS, and then we're bringing in these replenishing people. And so as the simulation runs further and further out, you're going to end up with only synthetic individuals. But yeah, but the goal is to keep our population 51 and older.
As you age the population, do you also look at things like confidence intervals as they become wider as you go further 100 years out from now?
Yeah, so the question is, are we going to look at confidence intervals? And so I have some stuff on how we think about uncertainty that I'll get to in a little bit. But yeah, you do see this kind of expanding band of confidence intervals as the simulation runs because we get less and less certain about what's going to happen. Okay, so this slide summarizes the kind of 4 types of simulation experiments that we do with the model. So you could imagine you could run the models as I just described them, and you would get a projection for what a cohort might look like into the future or what the population might look like into the future. And that's useful and that's really good. I'll show some results later that do just that. But we also do a lot of things where we start changing things that are happening in the simulation. And so the first type of thing that we might do is changing the initial characteristics of the population. And so that actually might be something even in a cohort simulation where I might start with my 51 and 52-year-olds, and they have a certain BMI distribution. And someone might say, well, yeah, but what if we had a different BMI distribution? How would their lives look different? And so we would adjust their BMI distribution in a particular way, and then compare the counterfactual world to the current world. A second type of thing that we do is changing the policy module. And so there we might be tweaking the age of eligibility for Medicare or particular parameters about what your Social Security benefits might look like or what the eligibility criteria for Social Security looks like. And so those are useful to inform policy decisions that people are making. They tend to be kind of reduced form, simple models of how we do this rather than the really complicated structural models that an economist might prefer. But from my perspective, I still find them useful. The third type, which we do an awful lot, is intervening on the transitions. And so if you think back to my diabetes example where I have this predicted probability of someone developing diabetes, I might change that probability. And so that might be that there is some lifestyle intervention that we know works and delays the onset of diabetes, or some new therapeutic that's coming online that might change the incidence of diabetes. Or even for someone who has diabetes, we might change the subsequent outcomes that result from that. So we might change the likelihood of them developing heart disease or their mortality rate, something like that. Those kind of parameter estimates that we're using tend to come from clinical trials or from some estimated causal model. And then we impose that on our simulation, and in our counterfactual world, we're now going to say, okay, we'd believe this to be the difference between the two groups because that's the only thing that I'm changing. And then the final type of experiment we do is changing the characteristics of those replenishing cohorts. And so part of this is just because of the flexibility we've built into it that, if people, they say, well, what if that obesity trend that you're always imposing on your replenishing cohorts doesn't happen? What would the world look like then? And so we do experiments like that. Any questions on the type of? No? Okay. Okay, so this is just to show off that we have our technical appendices that you can access. They lay out the technical details in gory detail if you want to know all about our estimation strategy and whatnot. It's all there in gory detail. Okay, so now I'm going to be talking a little bit about the kind of validation exercises that we do. So just to try to convince you that maybe what we're doing is reasonable. Maybe you should be skeptical. You're welcome to take away from it what you like. So what I'll show here is, I'm calling this handover. So I'll be showing the historic data that we've observed in the HRS, and then I'm going to show you what the FEM then produces from the transition models that we've estimated. And so this is a sanity check. I always say that this is what I'd show my mom or my dad. They're not microsimulation experts, but if you show them these pictures, they might say, oh, well, you guys are doing okay. So what I'm showing here is for men, and I'm just looking at 6 of our chronic disease outcomes. So the dots are what is actually observed in the HRS. And then the dashed line is how we're then extrapolating using the future elderly model. And what I'm looking for here is, are there any discontinuities? Are there any odd trends that I'm seeing? And for the most part, I'm pretty comfortable with this going forward through like 2040 or so. And then here's the same picture for women, and it looks about the same. Okay, so sanity check. I think we're doing a decent job there. And then we also do a lot of more formal validation exercises. And so I break this into sort of 2 groups of things. We do cross-validation. So in a cross-validation, we're going to randomly split our estimation sample into 2, estimate all those transition models using one half, and then we're going to simulate using the other half. And then we're going to compare what actually happens for the simulated group to those actual respondents. And so this means that we're stuck using historic data. So I'll be using, I'm starting my simulation back in 1998 and simulating through 2014, and then comparing what happened over time. And then the other type of validation, it isn't really validation, I call it external corroboration, is to compare our projections to external projections. So if there's some gold standard model for projecting the future population size of the US or diabetes prevalence or something like that, you can compare directly to those. So here's an example of the kind of cross-validation exercise that we do. So again, this started in 1998, and I'm showing through 2012. I think I did through 2014. And so the way to look at this is the FEM column, this is half of the sample, and the HRS column is those same people, but their actual observations in the given year. And I'm just comparing the means of these 2 groups, or of these populations. And so anytime you're seeing a p-value that isn't statistically significant, I see that as a good thing, because we aren't going to say, oh yeah, these are obviously different. And so you can see for the chronic conditions, after simulating for, 14 years, for the most part, we're matching up with what we actually observed in the HRS.
Was the HRS for those people that you did the simulation on?
That's right. So the transition models are estimated on one half of the simulation, on one half of the population, and then we're comparing the simulated version of the other half with the actual version of that other half. Yeah. So these are all people who were present in the HRS in 1998 that we've observed through 2012 in this case. But it's just half of them, just to be clear. The other type of internal validity checks that we've been doing more recently is instead of looking at means, we're actually looking at the individuals and seeing how well we did. And so you can think of this as comparable to like a 10-year risk score. So like in the Framingham population, they'll look at people who don't have heart disease, and then they'll estimate a model and say 10 years out, did that person develop heart disease or not? And then they'll compare how well they did. And so that's what this is doing. And I think I have pictures here. And so the key statistic that people focus on for these is the area under the curve. So I don't want to get way in the weeds on this, but like a fantastic model would have an area under the curve of 1. A model that doesn't do particularly well would have an area under the curve of 0.5. If you're worse than 0.5, you could actually just change your answers completely and you'd be better than 0.5. But you could think of like, for example, if I had a really noisy set of data and I estimated a mortality model, I might get back the correct mortality rate. And so the picture that I showed before where I was showing that the means matched up, I could get that without actually doing very well at the individual level. This is being much more specific and saying, for that individual, how well did we classify them into dying or not in this case? And so this is saying that 80% of the time, or 81% of the time, we're getting them right. We do better for something like dementia. So here the area under the curve is 0.88. And then for something like cancer, we're not doing as well. And so the kind of story that I'll tell with something like cancer is, for the most part, we're adjusting for smoking status, but there's not a lot else that's going to predict cancer. It's kind of a random event in the way that we're modeling things, and that's what you're seeing in the ROC curve. So these are useful for understanding, are we doing well in general, and then are we doing well specifically for individuals?
You can see how genomic data might help in certain of these kinds of conditions that might have a genetic component.
Yeah, that's a great, so the point is that if we had genomic data, we could bring that in as well. And so the HRS does collect genomic data. They have particular genotypes, but then they also have things like polygenic scores that you can bring in as well. And so if you were to incorporate those on the right-hand side of our transition models, we'd probably do much better at predicting the actual individuals who are developing cancer, for example, and then this would look better. Excellent point. And then last for chronic lung disease. Okay. So Anne asked about our approach to uncertainty, and so this is our current state of the art of how we do things here. It's very computationally intensive. Basically, the idea is that we're going to bootstrap everything. And when I say everything, it's not quite everything, but it's most things. So we're going to bootstrap the data that we're going to use to estimate our transition models. We're going to bootstrap the data that we're actually simulating, so the individuals we're simulating. We're going to bootstrap the data that we use to generate the trends that we're imposing on replenishing cohorts. And we'll bootstrap all the cost models as well. So there's lots of uncertainty that comes in that way. And the result of that is that we end up running millions of simulations and getting these confidence intervals that are incorporating every last bit of uncertainty that we've been able to incorporate. And then as Anne pointed out, you're going to see the confidence bands widen as the simulation runs. So that's our approach to uncertainty. I don't have any pictures of that. In terms of running the simulation, go ahead.
Did you also, it sounded like you got your predicted transition probabilities and then you took one draw from the uniform distribution. Could you do that more times, or is that not informed?
Oh, okay. So that's a good question. So when I described the simulation, it sounded like I was simulating each person once. That's not what we actually do. This is a Monte Carlo simulation, so I'm going to simulate each person thousands of times.
And then on top of that, now you're re-estimating the model without some people.
Exactly. And so on top of that, yeah. So yeah, I'm glad you asked that question, because that probably wasn't clear when I was describing the way the model works. So it's a Markov model, and then it also has a Monte Carlo component. And so the reason it has this Monte Carlo component is that when we have a probability of someone developing a disease or not, I have to assign yes or no. If I do that a lot of times, on average, I'm going to get back the right rate. And so we do it thousands of times, and I get back for the individual, I'll have the right sort of trajectory of them developing the disease instead of just like a jumpy 0 or 1 in a particular year. Okay.
Do experiments to figure out what's an optimal, sort of numbers of simulations to do?
Yeah, so the question is, did we do experiments to see how many simulations we should do? And the answer is yes. We've done it in different ways over the years. And it really depends on what you're trying to do and how small the subpopulations you want to summarize are. So for example, we do some work on 100 observations from the HRS, and that's going to require a lot more simulations than if we're just trying to get a population statistic. The population stuff, you can actually do 20 or 50 simulations and get a stable trajectory. When you start doing the kind of cohort analyses with very targeted interventions, we have to do a lot more. Yeah, good question. Okay, the simulation itself is implemented in all of the data processing and model estimation is done in SAS or Stata. The simulation itself is written in C++. Most of our users tend to work on a Linux server, although I support users who work on everything from Mac laptops through Windows servers that are running Linux emulation. This isn't meant to scare people off, but it is kind of challenging technically to get it up and running. But in terms of actually running the simulation and working with it, once it's up and running, people without a lot of technical savvy are working with it. All right, I want to talk through a handful of the kind of applications that we do just so you get a flavor for the kind of results that we produce, and you can see how you might think about using the model. I don't know if I'll do all of these, but I'll probably go through the US 2050, unless, yeah, I think that makes sense. Okay, so this project was one that we did here at the Schaeffer Center in conjunction with the Brookings Institute. And the premise of the work was, what is Medicare going to look like in 2030? So we know that the US population is aging rapidly. We know that they're getting sicker in terms of obesity, but they're smoking less. So we have those sort of different trends going on. But we really want to know, what is the burden going to look like for Medicare? Is it going to be really expensive? And what's that population going to look like? So the first bit that we wanted to do is make sure that we get the demographics right. And so sort of as a necessary input for the simulation, we're going to get the demographics right. And so here's what the Medicare population looked like in 2010. You can see it's predominantly white with some minority representation. By 2030, we're seeing a shift in that. When we do FAM, you see much more dramatic shifts in terms of the population distributions. Not to say that this isn't dramatic. And then let's see. In terms of the education of the groups, we're also going to see rapid transformation there. So you can see the less than high school group is 21% in the 2010 Medicare population, but by 2030 it's only 9%. And so that's going to have implications for all sorts of things, because you could tell a story that those who are higher educated can manage their medications better, for example. And so you might see differences there.
Population level, right? Or is this cohort?
The question is this a population level? This is the Medicare population. So this is everyone 65 and older in Medicare. So in 2010 versus 2030.
Where does the projection come from? What data are you using to project out these demographic features in 2030?
Okay, so good question. So the question is, where are the demographics coming from? So for this work, actually most of it is coming from the HRS itself, because the 65-year-olds in 2030 are currently, if I do the math wrong, 54 or so, and so they are already in the HRS. And so I think there are a handful of the replenishing cohorts that will come in sort of for the youngest people in 2030, but for the most part, these are actual HRS respondents that we've just aged up until 2030. Good question. In terms of the population distribution, so I keep mentioning how the population is getting older, and this is demonstrating that. So we have 40 million people on Medicare in 2010, and you can see that the oldest old, it's a decent number of people, but by 2030, it's going to be a more sizable group of people. And the important number here, I think, is that we go from 40 million people on Medicare to 67 million people on Medicare. And so just in terms of numbers alone, you're going to expect there to be a significant increase in the Medicare burden in the U.S., and I think that's known. I mentioned this in my initial motivation about risk factors moving in opposite directions, and I think ex ante it isn't clear which would win out. Like if you have declining smoking rates but increasing obesity, it isn't obvious to me which is going to dominate. So in terms of our obesity projections, I think there's one more. Yeah. So you can see that we're going to have based on our forecast, we're going to have a more obese Medicare population. And so this is anyone with a BMI of 30 or higher. And you can see that extreme obesity, which is a BMI of 40 or higher, is going to make up 7% of the population on Medicare. But as I mentioned, smoking rates are declining, and so this is just demonstrating that we're going from 57% ever smoked in Medicare to 48% ever smoked. So not enormous declines, but sizable. And so having now sold it as I don't know which way this is going to go, I think when you see a near doubling of one rate and a slight decline in the other, I think we can all say, well, yeah, I think obesity is going to win out. And that's what's going to happen. So at least in our projections. So here I'm showing the prevalence of these major diseases, many of which have obesity as a key predictor. And so you can see in 2010, we have these rates within the Medicare population. And then for 2030, we have these rates for the Medicare population. So just at the population level, we're just describing what's going on. You might be surprised that lung disease is increasing over time, given that I've just told you that smoking is declining. And the type of story I would tell there is that's really being driven by longevity. So it's not, these aren't age standardized or anything. This is really thinking about the entire Medicare population. And so we're going to see that right tail of age push out, and we're going to see increases in some of these things that happen for the oldest old. And then the challenging bit here from a policy perspective is that not only do these individuals have diseases, but they have multiple diseases, and the chronicity of disease is going up over time. So we're going from 26% managing 3 or more of these chronic conditions to 40% managing 3 or more. And so from a physician might find that more challenging to care for. The patient might find it more challenging to care for. And so that's going to be a big policy concern going forward.
Mortality from 2010 to 2030, are people living then 10 years longer?
So that's a great question. So she's asking what the change in mortality is. And I'll show, actually on my next paper that I'm going to present, I'll show you some of the trends in mortality because there's a lot of heterogeneity there. It actually turns out that the lowest SES people are not living much longer, but the highest SES people are. And so on average, there is this general trend, but it's heterogeneous. So. Okay, and so then the net effect here is, perfect. So this is at the Medicare population level. I'll show some more stuff on the heterogeneity in a second. So what this is showing is men. I'll just do the full slide. So men in 2010 had additional life years 17.7, conditional on making it to age 65. By 2030, there's 0.6 additional life years. So they are living a little bit longer on average. The challenge here, though, is that those additional 6/10 of a year are not healthy years. They're disabled years, and as you probably could have guessed from the chronicity of disease slide. And then similar, women have slightly larger gains in terms of total life expectancy, but the same story with this increased life expectancy is not healthy years. In fact, it's just disabled years, and moreover, the disabled years are increasing faster than the life expectancy is. So not the most encouraging result. Okay, so now I'm going to switch to a different paper. So this is one that we did for the National Academy of Sciences, and this is looking at disparities in life expectancy by income. So what we did is we broke the HRS into 5 SES groups based on their earnings between the ages of 40 and 50, their household earnings between the ages of 40 and 50. We figured that was kind of a level playing field for comparing different cohorts, because these people, like some of them in the HRS were 80 when they joined, so they weren't even working, but we have Social Security records to know what their earnings were when they were in their 40s and 40 to 50 age range. And so what we did here is we compared across cohorts. We estimated trends in life expectancy by these SES groups, and then tried to understand the implications for the federal programs. And so the kind of the basic idea here is that the federal programs were designed to be progressive in a particular way. And then if you have heterogeneity in terms of who's living longer, that's going to change the progressivity of the programs. And so we're trying to quantify what the impact is. So this is now splitting out the average life expectancy gain that we saw a couple slides ago into these different socioeconomic quintiles. And so I think this is for men. Yeah, it says male life expectancy on the left. The numbers here are conditional on making it to age 50, not age 65. That's why it's not 17.7, it's instead of 26.6. But what you see here is that for the oldest cohort, that 1930 birth cohort, the lowest SES group had a life expectancy of 26.6, but in the 1960 birth cohort, the lowest SES quintile has life expectancy of 26.1, so declining life expectancy for the poorest group that we're looking at. And then on the flip side, though, the richest cohort has an enormous gain in life expectancy over this 30-year period. And so this is all reduced form estimated from the HRS using a linear time trend, looking at these different cohorts and what's happening with the quintiles. And so then what we do is we look at what the implications are for these programs. And so this is I think this is the baseline story. And so what this is saying is that the quintile 1, this poorest group, in aggregate, they're getting roughly the same level of benefits from the federal government. This $126,000 for the older cohort, $122,000 for the younger cohort. Whereas the richest group went from $229,000 to $295,000. And that's really being driven by that increase in life expectancy. Yeah.
I was wondering, is this mostly being driven by the chronic disease, that type of predictor, or does HRS ask about opioids or any of these other kind of tougher to measure, more sensitive?
So great question. There's nothing about opioids in this modeling. There are some questions on substance use and things like that, which we've tried to bring in, like binge drinking, but none of that is here either. This is all incredibly reduced form. I want to be like totally upfront about that. Like, it's super simple. It's like, what is the trend in these cohorts for mortality? Yeah. And so, so back to the progressivity story. So what this is saying is that, you know, we had this story where the groups are getting, you know, the richest group is getting more benefits than the poorest group, but that gap is now widening. And so that might not be what you want from a policy perspective. Interpret that as you like. So then the next step of what we did in that analysis was then to assess give our estimate of what would happen if we started changing the policy. So in Washington, there's a lot of discussion about, well, what if we raised the Medicare eligibility age, or what if we made people work until they were 70, things like that, before claiming Social Security benefits. And so this is an example showing what would happen if we raised the normal retirement age. I think it's for 5 years. The slide is not very clear about what's actually being measured here. But if you flip back and forth between the previous and the second one, you can see that each of the groups are impacted differently. And so what it let us do is in the paper, we then look at many different policy proposals and we assess just how much they impact the groups differentially. Okay, last paper I want to talk about is, this actually uses FAM, so this is our 25 and older simulation, and this was thinking about what is 2050 going to look like. And so I just wanted to get some FAM in here for flavor. So here we see, this is our kind of our baseline result using FAM for 2018, 2030, and 2050. And you can see the demographic shift. So for example, the Hispanic group goes from 15% to 25%. And again, this is the 25 and older population. So sometimes people have particular statistics that they've memorized, but that's not one that most people know. But that's an enormous increase in the Hispanic population. And you can see that the total population, 25 and older, is going to increase by about 45 million people. As I mentioned before, we have that slow increase in BMI, and we have that decline in ever smoking and current smoking. And so here, again, we have those kind of diverging trends that we might want to understand. And so then this looks at the prevalence of particular diseases at the population level. So again, this is now 25 and older. And you can see the same kind of story that I showed in the Medicare 2030, so I'm not going to focus on it too much, but more diseases, more chronicity of disease, more functional limitations. Part of that is driven by the population being a couple years older on average. Part of it is being driven by the obesity epidemic. Yeah. And then finally, the last piece that we did here was calculate all of the revenues and benefits from the government programs and trying to understand just how big the fiscal burden of these in a given year is. And let me see if I have it. Oh, yeah, I do. Okay. And so this is kind of our baseline result of how big these programs are going to look. And so OASI here is the Social Security retirement program. DI is the disability program. And then Medicare and Medicaid are self-explanatory. But you can see, for example, in terms of Social Security benefits, they are certainly increasing a lot through 2050, and that's driven by the aging of the population. Medicare benefits, in the way we're modeling it, are going up at an even faster rate, and that's being driven by both growth in the population, but then also just cost growth within the Medicare program. And so then what the paper ultimately does is it looks at, well, what if we could prevent these diseases from occurring? So would we be able to save a lot of money in any of the given programs? This slide is not the money one. This is just the relative rates. This is so the setup here is when I was describing the kind of interventions that we do, now I'm going to intervene on people developing diabetes, and I'm going to say, well, what if there's a perfect pill that prevents people from developing diabetes? Or you could think of it as once people have developed diabetes, it doesn't impact their health in any other measurable way. And so what this intervention does is, this is showing now at the population level, if we were able to do that, what the impact would be. And so this shows some of the strength of the modeling that we're doing. So if you look at the 2050 column, you can see that the diabetes rate plummets by 87.9%. It's not everyone, because there were some people initially who already had diabetes and I didn't do anything for them. But then you can see the kind of additional things that happen when you do prevent diabetes. And so what that means is that more people are living longer. And so that's that 1.7% growth in population, which is enormous from a population perspective. And then you see changes in other diseases that are correlated with diabetes. So heart disease is declining because diabetes is declining. Something like lung disease, I guess, is increasing. I'll tell the story that that's because people are living a little bit longer and now they're developing developing lung disease. And so what it lets you do is have a kind of a full picture of any of these offsetting things that might be occurring between increasing the longevity of individuals and then cutting other diseases. And then finally, then we tried to understand the fiscal implications for these things. So this is looking at all of the kind of big federal level, well, I guess we have state taxes as well, federal level programs, and understanding if you were able to perfectly prevent diabetes, how big of an impact would it have on Social Security or Medicare? Would it make these programs solvent? That's really the fundamental question that we were asked to address. And I wouldn't turn my nose up at saving 7% of Medicare's burden, but the reality is that would not make Medicare solvent for more than a few more years. So it's a good story and a bad story because the health stuff alone is not going to be enough to, in our modeling, would not be enough to make these programs solvent. But from an individual perspective, it's fantastic because people live longer, healthier lives. So, and then let's see. Okay, so then this is just showing we did the same analysis for 6 of the chronic conditions, so you can compare the net impact. And so this, what this does is it combines the prevalence of the diseases with the total benefits, and so you can kind of gauge like, well, which one would have a bigger impact on Medicare or Medicaid or Social Security, and then you can aggregate them all and see what the total net benefit is. But you can see that, for example, hypertension and heart disease are dominating here. I think they're the 2 biggest savers, certainly in terms of Medicare. Heart disease, leading cause of death for people in America. Hypertension, leading risk factor for other diseases that like stroke that are expensive. And finally, this does it in percentage terms, so you can see the sort of the net benefit. And then this is showing on the flip side what are the additional revenues that would be received as people didn't have these diseases, so they would be able to work longer and try to understand any additional fiscal income that the government would have from there. And the same thing in percentage terms. And then finally, this is the net fiscal benefit. This is sort of the punchline of the analysis. So it shows that through 2050, like if we were able to today cure these diseases individually, what would the benefits be? And so hypertension in net present value, it's $3.7 trillion. Something like chronic lung disease, $310 billion. So large amounts of money, but not enough to make the program solvent. That was the ultimate story. And I think I'll stop there to take any questions, if that's okay. Go ahead.
So don't Social Security or restriction do some of the projections themselves?
Yeah, so the question is, does Social Security do these projections themselves? And the answer is yes, they do. We do compare to them as a validation exercise in the technical appendix. You'll see that. I think that our modeling, it always has that risk factor to chronic disease to functional limitations story that maybe Social Security doesn't always capture. So they might do something more at like a demographer kind of level than this way.
So the risk factors are also in the mortality model?
For my modeling? Yeah, the risk factors are in the mortality model. I should have shown that one, yeah. Yeah, the things that really drive mortality in FEM are age, not surprising, chronic conditions, but the ones that really are strong predictors are the functional limitations. So the ADLs and the IADLs, they really do indicate poor health. And so it's important to get those right.
And how well do you think the technology advancement is captured in this approach?
Okay, so she's asking about the technology advancement. And so the way you can think about this is it's kind of like a period life table. And so basically it's saying, I've estimated my transition models in the health and retirement study in the recent years, and I'm going to keep applying those transition models. And so it's kind of like those people are living their lives constantly in like the 2000s and 2010s. And so you probably don't believe that. The one place that we do adjust for things is we have an all-cause mortality reduction. And so that is basically saying that we're investing in all this medical technology and that's going to extend lives. And so we're just extrapolating the trend that you've seen over the last century, basically. That we're using the same trend that the Social Security uses in their actuarial reports. And so there is something there in terms of medical technology, but not a lot. And so that's where we start doing a lot of our experiments where we say, well, what if there were this intervention that did this for diabetes? What would the potential impact of that be? Yeah, good question. Go ahead, Seema.
How granular can you be in terms of like immigrant populations, just capturing?
Yeah, so the question is how well can we do with immigrant populations? And so at the national level, we haven't done a lot there, but for the Los Angeles County version, we have. We worried a lot about, there were 5 dimensions that we were actually reweighting people to match characteristics of Los Angeles County, and that included born in the US or not. And it got as fine as looking at Hispanicity and then looking at people who were Cuban versus Mexican, basically, broadly speaking. So it's a challenge because within the HRS, you end up with small groups of people, like just in terms of the sample size of the HRS. But for the questions that we want to answer, if we're willing to do stuff with synthetic cohorts or do some more stuff to bring in more data, we start looking at it that way. Great.
Is HRS translated into different languages for when they survey people?
So the question is the HRS translated for different languages in the survey? I think the answer is yes, but I'm not certain.
Only in Spanish.
Only in Spanish. Okay. Any other questions in the room? Rebecca?
Following up on the question about technology advancement, I was just wondering a little bit more about how you could do include year itself as a predictor, or like some polynomial of year, just because potentially interacted with, say hypertension treatment or something like that. That way to extrapolate, improvements in treatment and future improvements. Mm-hmm.
So the question is, do we incorporate a year trend in any of this modeling? And the answer is typically no. There's nothing like that, except the work that I showed for the National Academy of Sciences. We did, in fact, estimate a year trend in the mortality hazard. That was something that we did do. The way to think about technology advancement in the model, if we did think that there was some reduction in hypertension effects over time or something like that, is the simulation is built to be very flexible in terms of incorporating whatever assumption you want to make about that. But we don't estimate that from the HRS data itself. Yeah, great question. Anyone else? Is there just?
Can you talk a little bit about how you would take a national model and then customize it to a more local population? What do you do? What variables would you adjust?
Okay, so the question is, how do we take a national level data set and make it more of a local version? And so we do that the main way that we do that is via sampling weights. And so the HRS has its sampling weights that are assigned by demographic characteristics, and we will find a source for the characteristics of the individuals that we want to be modeling. So if that's Los Angeles County, we'll get something from Los Angeles County for the state, or from the state of California. We've talked about doing it also looking at the region that the respondents actually come from. We were going to do a project with another state, which hasn't yet happened, that was going to take that approach instead. For California, we kind of said, well, California's what, 10% of the population, something like that. And so we were kind of willing to just take everyone and say, well, what if they look like Californians? Okay, so the reweighting is a key component of what we're going to do there. But then there's also a lot of validation that happens as well. So in the Los Angeles County stuff, this was actually a previous RCMAR project, was developing the Los Angeles County FEM. And they had a lot of survey data locally. And so in addition to getting the demographic characteristics right, and so that's those 5 dimensions that I mentioned before, they also wanted to look to see if they're getting chronic disease prevalence right and obesity rates right. And so they had a local, I think it was the, I'm going to say it was the CHIS, but I think that's the California level. There's a Los Angeles survey that they were able to match levels of chronic disease and obesity to. So they felt fairly confident that they were getting back the right results. And then they did a lot of validation of the projection that they were making, looking at death records in Los Angeles and making sure that they were getting similar mortality rates, for example. So I'll just say that if you have questions about this stuff, please email me and ask questions. I love talking about this stuff. I love working on this stuff. We have a really rich set of projects that we do here at the Schaeffer Center. We love external collaboration. If you have a project idea, I'm happy to talk about it with you. So thank you very much.